The decision that changes everything. If you're trying to choose between sleeve gastrectomy, gastric bypass, or mini gastric bypass, you're not just comparing surgeries. You're choosing a metabolic strategy. And here's what most people don't realize. All three procedures reduce stomach size, but they do not work the same way. They do not affect hunger the same way. They do not influence type 2 diabetes the same way. And they absolutely do not carry the same long-term risks. In the United States, sleeve gastrectomy is currently the most commonly performed bariatric surgery, accounting for more than half of all weight loss procedures. Roux-en-Y gastric bypass remains the gold standard for metabolic correction and diabetes remission. Mini gastric bypass, also known as one anastomosis gastric bypass, is less common in the US, but widely performed in Europe and parts of Asia, and is gaining attention for its strong weight loss results. But popularity does not equal superiority. The right choice depends on your BMI, your history of reflux, your diabetes severity, your insulin dependence, your eating patterns, your long-term adherence capacity. Let's start with sleeve gastrectomy. During sleeve surgery, approximately 75 to 80% of the stomach is permanently removed. What remains is a narrow tube, about the size and shape of a banana. There is no intestinal rerouting. No bypass. Food follows the normal digestive pathway. But here's what makes sleeve powerful. It significantly reduces ghrelin, the hunger hormone produced primarily in the upper portion of the stomach. That reduction leads to decreased appetite. Patients often describe feeling satisfied with much smaller portions. However, sleeve is primarily restrictive. It limits how much you can eat. It does not significantly reduce nutrient absorption. Now compare that with Roux-en-Y gastric bypass. This procedure creates a small stomach pouch, about the size of an egg, and reroutes part of the small intestine. Food bypasses a segment of the upper intestine. This produces two effects: restriction and malabsorption. But more importantly, it triggers powerful hormonal shifts. GLP-1 levels rise significantly. Insulin sensitivity improves rapidly. In many patients with type 2 diabetes, blood sugar improves within days, before major weight loss even occurs. Mini gastric bypass works similarly to Roux-en-Y, but with a single intestinal connection instead of two. It is technically simpler and often shorter in operative time. It also produces strong metabolic effects. However, because bile flows differently in this configuration, bile reflux can occur in some patients. And bile reflux is not the same as acid reflux. So the question is not, which surgery works? All three work. The real question is, which mechanism best matches your metabolic disease? Because bariatric surgery is not cosmetic. It is metabolic engineering. And understanding the mechanism is the first step toward choosing correctly. In the next section, we will compare weight loss outcomes in real numbers and what those numbers actually mean long-term. Weight loss power. Which surgery produces more results? Now let's talk about what most people really want to know. Which bariatric surgery produces the most weight loss? Because when patients compare sleeve gastrectomy versus gastric bypass versus mini gastric bypass, the first metric they look at is the number on the scale. But weight loss percentage alone does not tell the whole story. In the United States, sleeve gastrectomy accounts for approximately 55 to 60% of all bariatric procedures performed each year. Roux-en-Y gastric bypass represents about 35 to 40%. Mini gastric bypass is performed less frequently in the US, but it is increasing in international popularity. On average, sleeve gastrectomy produces about 20 to 30% total body weight loss within 1 to 2 years. Roux-en-Y gastric bypass typically produces about 25 to 35% total body weight loss. Mini gastric bypass often shows similar or slightly higher weight loss compared to classic bypass in some studies. But here is the nuance most people miss. Weight loss is influenced by three primary mechanisms: restriction, hormonal modulation, malabsorption. Sleeve gastrectomy works mainly through restriction and hunger hormone reduction. Patients feel full faster. They experience reduced appetite, but the intestine remains intact. That means nutrient absorption remains relatively normal. For many patients, this balance is enough to produce durable results. However, long-term data suggests that gastric bypass may have slightly stronger durability in maintaining higher percentages of weight loss over time, particularly in patients with higher starting BMI. Why? Because gastric bypass combines restriction with mild malabsorption and stronger hormonal shifts. It changes gut signaling in a way that reduces hunger, increases satiety, and alters glucose metabolism. Mini gastric bypass also combines restriction and malabsorption, but through a simpler anatomical configuration. Some studies suggest it may produce slightly greater early weight loss compared to sleeve. However, long-term comparative US data remains more robust for Roux-en-Y. Now here is where it becomes clinically important. If a patient has BMI above 50, long-standing obesity, multiple metabolic conditions, bypass procedures may provide stronger initial weight reduction, but that does not automatically mean sleeve is inferior. Sleeve gastrectomy has advantages: shorter operative time, no intestinal rerouting, lower risk of certain internal hernias, simpler anatomy long-term. However, sleeve has a known drawback. It can worsen gastroesophageal reflux disease. In some patients, reflux symptoms may appear or intensify after sleeve surgery. That is a critical factor because weight loss success should not come at the expense of chronic discomfort. Bypass, on the other hand, often improves reflux, which makes it a preferred option in patients with severe GERD. Mini gastric bypass introduces another variable. Because bile flows closer to the stomach pouch, bile reflux may occur in certain patients. And bile reflux is not simply heartburn. It can cause persistent irritation. So again, the question is not simply, which surgery produces more weight loss? The better question is, which mechanism aligns with your anatomy and disease profile? Because sustainable weight loss depends not just on surgery type. It depends on adherence to post-bariatric surgery diet. It depends on long-term supplementation. It depends on behavioral adaptation. All three procedures require structured eating, protein prioritization, vitamin supplementation, long-term follow-up. The surgery creates opportunity. Behavior maintains the result. In the next section, we will shift focus to something even more critical than weight loss: type 2 diabetes remission, because for many patients, metabolic correction is the true priority. Type 2 diabetes. Which surgery has the strongest metabolic effect? Now we arrive at what may be the most important question for many patients. Not weight loss, not appearance, but diabetes. If you are living with type 2 diabetes, choosing between sleeve gastrectomy, Roux-en-Y gastric bypass, and mini gastric bypass is not just a matter of preference. It is a metabolic decision. In the United States, more than 37 million people live with diabetes, and obesity remains the strongest modifiable risk factor. Bariatric surgery is often referred to as metabolic surgery for a reason. Because its effect on blood sugar is not just secondary to weight loss. It is hormonal. Let's start with Roux-en-Y gastric bypass. This procedure has the strongest long-term data for type 2 diabetes remission. In many studies, remission rates range from 50 to 80%, depending on duration of diabetes and severity at the time of surgery. Some patients experience normalization of blood glucose levels within days, before significant weight loss even occurs. How is that possible? Because gastric bypass alters gut hormone signaling dramatically. When food bypasses the upper intestine, it stimulates increased production of incretin hormones like GLP-1. GLP-1 enhances insulin secretion, it improves insulin sensitivity, it reduces hepatic glucose output. This hormonal cascade improves glucose control rapidly. That is why gastric bypass is often considered the most powerful procedure for patients with long-standing diabetes, high insulin requirements, poor glycemic control, advanced metabolic syndrome. Now let's talk about sleeve gastrectomy. Sleeve also improves diabetes, but through slightly different mechanisms. It reduces ghrelin. It accelerates gastric emptying. It improves insulin sensitivity over time. Remission rates for sleeve are strong, often ranging between 45 and 65% in early-stage diabetes. However, in patients with severe, long-standing diabetes requiring high-dose insulin, bypass tends to show stronger and more durable remission. Mini gastric bypass also produces significant metabolic improvement. Because it includes intestinal bypass, it triggers hormonal responses similar to Roux-en-Y. Some international data suggests comparable diabetes remission rates. However, long-term US-based comparative data remains more extensive for Roux-en-Y. Now here is something critical. Diabetes remission depends heavily on timing. The shorter the duration of diabetes before surgery, the higher the chance of remission. Patients diagnosed within the past 5 years often respond more dramatically. Patients with preserved pancreatic beta cell function also respond better. If insulin production capacity is already severely reduced, remission may be less likely, but improvement still occurs. And improvement matters. Even if full remission does not happen, surgery often leads to lower A1C levels, reduced medication burden, lower cardiovascular risk, improved lipid profile, decreased inflammation. This translates to reduced long-term complications. Now let's introduce nuance. If a patient has severe GERD and diabetes, bypass may offer dual benefit. If a patient has moderate diabetes and no reflux, sleeve may be sufficient. If a patient has high BMI and significant metabolic disease, mini gastric bypass may be considered depending on surgical expertise and risk profile. But again, no surgery is universally superior. Each works through different metabolic pathways. The best bariatric surgery for diabetes is the one aligned with disease duration, insulin dependence, BMI range, reflux status, nutritional tolerance, long-term compliance. Because metabolic surgery is not just about remission, it is about stability. And stability is what protects organs long-term. In the final section, we will translate all of this into practical guidance. Who should choose sleeve? Who should choose Roux-en-Y? Who might consider mini bypass? And what risks must be clearly understood before making a decision? Which surgery is right for you? Risks, reflux, and long-term reality. Now let's make this practical. If you are deciding between sleeve gastrectomy, Roux-en-Y gastric bypass, and mini gastric bypass, you don't need hype. You need alignment, because the best bariatric surgery is not the one with the biggest average weight loss. It is the one that fits your medical reality. Let's break this down clearly. Sleeve gastrectomy may be ideal if you have moderate obesity. You do not suffer from severe acid reflux. Your type 2 diabetes is early or well controlled. You prefer simpler anatomy. You want to avoid intestinal rerouting. You are comfortable committing to strict dietary structure long term. Sleeve is technically simpler. Operative time is often shorter. There is no intestinal bypass. And long-term vitamin deficiencies tend to be less severe compared to bypass procedures. However, sleeve has a known risk. Reflux. Because the stomach becomes a narrow high-pressure tube, some patients experience worsening gastroesophageal reflux disease after surgery. For patients who already suffer from severe GERD, sleeve may not be the best choice. Now consider Roux-en-Y gastric bypass. This procedure is often preferred if you have severe reflux, you have long-standing type 2 diabetes, you require stronger metabolic correction, your BMI is significantly elevated, you need dual impact, weight loss and glucose control. Bypass reduces acid exposure and often improves reflux symptoms, but it introduces more complexity. There is intestinal rerouting. There is mild malabsorption. There is higher long-term risk of certain vitamin deficiencies, including B12, iron, calcium, and fat-soluble vitamins. Supplementation becomes non-negotiable. Regular blood monitoring becomes essential. Mini gastric bypass may be considered if you need strong weight loss. You have metabolic disease requiring aggressive intervention. You are treated in a center experienced with OAGB. Mini bypass is technically simpler than Roux-en-Y, but still includes intestinal bypass. It may produce powerful weight loss and metabolic improvement, but it introduces a different risk. Bile reflux. Unlike acid reflux, bile reflux involves digestive bile flowing toward the stomach pouch. It can cause irritation and discomfort. Not every patient experiences it, but it must be discussed honestly before surgery. Now here is what viral content rarely explains. Surgery does not eliminate responsibility. All 3 procedures require a structured post-bariatric surgery diet, protein prioritization, avoidance of high-sugar foods, vitamin supplementation, regular medical follow-up, behavioral adaptation. And long-term success depends on adherence. Gastric bypass versus sleeve is not just about numbers, it is about lifestyle compatibility. If you struggle with grazing behavior or liquid calorie consumption, bypass may offer stronger metabolic guardrails. If you prioritize anatomical simplicity and accept slightly less aggressive metabolic impact, sleeve may be appropriate. If your metabolic disease is severe and you are evaluated in an experienced center, mini bypass may be discussed. But remember, there is no universally superior procedure. There is only individualized medicine, and that decision should always involve a bariatric surgeon, an endocrinologist, a dietitian, a psychological evaluation. Because the goal is not just weight loss, the goal is metabolic stability, reduced cardiovascular risk, improved diabetes control, lower long-term mortality, and improved quality of life. If you are deciding between sleeve versus gastric bypass versus mini gastric bypass, the real question is not, which surgery is trending? The real question is, which surgery matches your biology? In the next video, we will go deeper into bariatric surgery recovery, complication rates, and what they don't tell you about life after surgery. Because the decision does not end in the operating room, it begins there.